A very important committee is the IT committee of DHP, which is not only just looking at a platform, but how we use all this information. Scott Bloor and Rick Lane co-chair this, and Scott Bloor has some very exciting and important information to present.
Okay, so the charge of our committee was to essentially look at everything that everybody else has already presented to you and evaluate and implement the essential information technology needs of DHP in the near, intermediate, and long-term future. If you don't like any of the stuff that you hear or that we do in the future, the chair is Rick Lang, so you can let him know. If you do like the stuff, you let me know. So why are we doing this? And as Scott pointed out, to be an integrated healthcare network, we need to be able to share information from primary to specialist to the hospital, back to the specialist, to the primary, to the nursing home, and so on. We have to be able to share the information with Delaware Valley ACO, and we have to know when our patients not only receive care within our network, but when they receive care outside of our network. Population management is the kind of the key term here. When we're talking about being able to manage groups of people who have a disease process and apply certain criteria to those diseases so that we can keep the quality of care very high but the costs low, and then also reduce redundancy. Medicare, by 2016, wants to reimburse us 30% or have their 30% of their reimbursements based on value-based care, not how many patients you get through and not what procedures you do, and 50% of their reimbursements by 2018 based on value care. Meaningful use, we all have to be able to grab that data, their demographics, and report it. Tandem, and of course, Renaissance, which is not dead. So our committee started with 3 main tasks. We started evaluating the current electronic health record. As Scott pointed out, many of the physicians in the room are using NextGen. We're also evaluating or being part of the Health Share Exchange of Southeastern Pennsylvania. And of course, we need to continue to evolve what software capabilities we have for population management. So when trying to put all this together, it would be ideal to have most, if not all, of the providers on one ambulatory EMR. That's kind of the pie in the sky. If we could have all the specialists, all the primary cares using the same ambulatory EMR, that would make this job super easy. So first step was to set out to evaluate NextGen and see, is this truly a great system that we can move forward with? Does it have a lot of deficits that will cause us to stumble? And where do we go if that's the case? And so we went out and hired a consultant company called Medmatica, and we asked them to come in. What Medmatica did was they came in and interviewed users, physician users, specialist users. They interviewed office managers, and they did surveys, and they were able to collate a lot of information about how the physicians affiliated with Doylestown Hospital think of NextGen. So this list was just a few of the things that the physicians didn't like about NextGen. I'm not going to go through every one of them, but highlight a couple. They found it difficult to use, that it was not intuitive in the design, that it had too many clicks. So the next slide is what we found positive about NextGen. No, I'm kidding. Isn't that sad? So I'm so proud. I made this graphic, and then I see Al with all his pictures and all that. It's like, that's cool. So thanks. But Medmatica also had experts to look at NextGen as well. So what they did is they had people, experts that had actually helped either design or work with NextGen in the past. They combined, you can see the red circle. The first number, 63%, was actually the physician's rating of NextGen. Did it, and we all kind of felt that it wasn't meeting what we needed. The experts actually felt that 78% of what NextGen needed to do was deficient. So that, at least we weren't necessarily wrong. And then KLAS is a national company that rates EMRs and gives you an idea of, are the EMRs where they should be? Are they doing different functions like, do they have a good sales and contracting? How's their implementation? What's their service support? How's the functionality and upgrades? And NextGen for their EMR was felt to be below national average for most of these. The practice management was actually quite, it's pretty decent and does fairly well. So the evaluation essentially that we took to, that came back to our committee members is that it's time to reevaluate where we are with the EMR that we're using and to decide if it's time to replace NextGen or are we just not using it effectively and there's a better way to do it. So there's 500 EMR vendors in the country. Medmatica has helped us narrow it down to 9. Our committee will be tasked to narrow it down to 3, and then we'll hopefully be able to bring these vendors in and provide scripted demos for all of the physicians, specialists of primary care, scripted demos that we put together that would pretty much condense a week's worth of office work for us into an hour script. So it's not what they want to show us in the bells and whistles, but it shows, what do you do when you get the phone call and you want to record it, and how do you send the referral, and you do it real time within an office. So those will be some of the things that our committee will be working on, and we hope to have these demos up and running by December, January timeframe. So we're moving fairly quickly. The second aspect of our committee is the Health Share Exchange of Southeastern Pennsylvania. And essentially, this is a health information interface that is touching about 1/3 of all Pennsylvanians in our region. About 1/3 of all the folks in Pennsylvania live in our region. It covers 15,000 physician lives, 42 hospitals, and 4 major health insurers. And what does HSX do? It's taking hospitals, it's taking healthcare centers, ambulatory care EMRs, and insurance claims data to collate it together and be able to push information real time at the point of care, either in the hospital or in your office. So those of us using NextGen, if you've gotten the implementation specific document in your PAQ, I know a lot of you don't know what that is, but it's supposed to act as a summary of care that helps tell you what they were admitted for, when did they go in, when did they come out, what were their discharge medications, what were the procedures that were done for them. There's a lot of work to be done on this, but it's an exciting possibility to be able to link all of this information together. Right now, we can provide electronic transfer summaries from one provider to another provider that gives important information. There's a pilot program currently in the emergency room with patient summary data, and then we're about to launch an out-of-network alert that when somebody ends up at cardiology at Jefferson, we'll get an alert with a nice little summary of what was done. So this is an evolving process. If you haven't heard of HSX or you're not part of it, then I would encourage you to contact either Rick or Rita and become part of this.